Alright everyone, Kitty Clinical here with our third part of the Biochem portion of the USMLE Step 1 Thoughts series. We're going to be talking about de novo pyrimidine and purine synthesis. Before I get started, just so you know, there's going to be a lot of abbreviations. I am not going to be reading out all of the abbreviations. I am going to be saying PRPP rather than phosphoribosylpyrophosphate pyrophosphate. I think it just makes a lot more sense for me to be saying the letters. And number two, I am not going to be putting out any diagrams on these videos. I'm going to be walking you through the diagrams so that you can kind of see them yourself. But if you want a visual, please go do yourself a favor, go to Google Images or the internet and type up pyrimidine-based production, purine-based production, and look at the pathways yourself. The point of that is because I'd much rather just talk about it. I want this to be more of like an audio rather than a visual. Yeah, I do have the cat talking here. I think that's kind of cute, but I would like for you to maybe study while you're looking at your own study material, right? So we talk about pyrimidine-based production and purine-based production. Purine-based production, or reuse from salvage pathway, is de novo and it requires aspartate, glycine, glutamine, and THF. Pyrimidine-based production requires aspartate, and they both have a common denominator, and that is the ribose 5P to PRPP via the PRPP synthetase. And you'll see that the PRPP is involved in both the pyrimidine and the purine-based production, and that is why it's kind of like the common denominator of the two pathways. So we'll briefly talk about the purine production or reuse from the salvage pathway. The PRPP, we'll start with that, goes through a bunch of different processes that eventually ends up with IMP. IMP will split off into AMP and GMP. And there's a couple of important medications that you should know. The first two are going to be 6-mercaptopurine and azathioprine. The 6-mercaptopurine and azathioprine are involved in preventing PRPP from going to IMP. 6-mercaptopurine has its prodrug, azathioprine. They both inhibit the de novo purine synthesis, and azathioprine, mainly metabolized via purine degradation pathway, can lead to immunosuppression when administered with xanthine oxidase inhibitors. The other two that I want to talk about is mycophenolate and ribavirin. Mycophenolate and ribavirin inhibit inosine monophosphate dehydrogenase, which, as you can probably imagine, means that it inhibits the IMP to GMP pathway, right? So mycophenolate, you might not necessarily see that often. It's also known as myfortic. It's commonly used in kidney transplant rejection prophylaxis, and you don't necessarily need to know that, but I am going to say some of these things for the clinical correlation in case you need it for your additional knowledge. You don't necessarily need to know this for step 2. I guess you might need to know mycophenolate for step 2, but myfortic, also known as mycophenolate, used primarily in kidney transplant rejection prophylaxis. It's dosed 720 milligrams PO/BID. And as I say PO/BID, I'm going to say that to you and explain to you what that means. PO means oral, and BID means twice a day. All right, so that's going to be it for those two medications. The mycophenolate ribavirin inhibit the IMP dehydrogenase we talked about. Ribavirin, really quickly before I move on, ribavirin has many uses. The inhalation is off-label for RSV. Its inhalation is 20 milligrams per milliliter, and it comes in an oral tablet, 200 milligram tablet or capsule, and it's a direct-acting antiviral combination treatment for hepatitis C, and typically that dosage is 400 to 700 milligrams PO/BID. So you don't necessarily have to know the dosing, but I'm going to say it here just for your own educational purposes, for your own interest. That's a lot of words. We'll pause on the purine-based production pathway for now, and we'll move on to the pyrimidine-based production. You'll start with glutamine and carbon dioxide. That requires 2 ATP. So you go from 2 ATP to 2 ADP plus the phosphate and glutamate. It's going to use CPS2, or carbamoyl phosphate synthetase 2, to get you carbamoyl phosphate. So you again, glutamine plus CO2 gets you carbamoyl phosphate via CPS2, and that requires 2 ATP. Carbamoyl phosphate together with that aspartate that we talked about before. Remember, the pyrimidine-based production requires aspartate. Carbamoyl phosphate and aspartate will get you orotic acid. And that actually is going to be inhibited by leflunomide. Leflunomide inhibits dihydroorotate dehydrogenase. And you'll see dihydroorotate dehydrogenase as a very, very complicated word. You're going to see that a lot, folks. And leflunomide is usually dosed, 10 milligrams or 20 milligrams, and it's used for the daily treatment of rheumatoid arthritis. So you get orotic acid here, and orotic acid plus PRPP is going to get you UMP via the UMP synthase. And UMP synthase is impaired in orotic aciduria. Now, this is going to get us to our next hot topic, which is inhibition and general principles for endocrinology and biochemistry. The big concept here is that when you inhibit the enzyme that gets you from point A to point B, well, point A is going to be backed up and point A is going to build up, right? So when your UMP synthase isn't working very well, such as in the case of orotic aciduria, you're going to get a lot of buildup of orotic acid because that orotic acid is not going to get to the UMP. So the orotic acid is going to build up and you're going to have a lot of orotic acid, which is why it's called orotic aciduria, right? Because you're going to build up that orotic acid. And I would imagine the same thing with leflunomide, right? Leflunomide inhibits dihydroorotate dehydrogenase, so you're probably going to get a backup of the carbamoyl phosphate. So keep that in mind, very high yield. Orotic acid plus PRPP gets you UMP. UMP becomes UDP. UDP splits off into CTP, and it also gets you lowercase d UDP or DUDP. Just say UDP. I'll just say DUDP for now. UDP splits off into CTP and DUDP, and UDP goes to DUDP via ribonucleotide reductase. And that ribonucleotide reductase is inhibited by hydroxyurea. Hydroxyurea, as we mentioned before, inhibits ribonucleotide reductase. It is used for a lot of things. And it's also used in the off-label treatment of various disease processes as well. Hydroxyurea is used for chronic myeloid leukemia refractory treatment. It's used for squamous cell cancer of the head and neck. It also has an off-label use for sickle cell disease, off-label use for polycythemia vera, and an off-label use for essential thrombocythemia. Now, you might not know what polycythemia vera is. It's basically you get a lot of RBCs, a lot of hemoglobin, thrombocythemia, also a lot of buildup of platelets, right? Thrombo. And I want to emphasize that you should not confuse hydroxyurea with hydroxychloroquine, because I've definitely done that a couple times. Hydroxyurea is what we're talking about right now. Hydroxychloroquine sulfate, or Plaquenil, is used for lupus, rheumatoid arthritis, malaria prophylaxis, or malaria treatment. So that's hydroxychloroquine. We are talking about hydroxyurea here, okay? So just want to make that very, very clear because it's very easy to get your drugs mixed up in the bunch, right? All right, so we've talked about ribonucleotide reductase being inhibited by hydroxyurea, and we talked about the uses of hydroxyurea. That UDP goes to DUDP, that DUDP goes to DUMP or dump, and that the dump, together with a long worded thing called N5N10 methylene THF, gets you both DHF and DTMP via thymidylate synthase. So this thymidylate synthase, it does two things here. It's involved in one mechanism, going from dump to DTMP, and from N5N10 methylene THF to DHF, right? So that N5N10 methylene THF becomes DHF, and the dump becomes DTMP. And that thymidylate synthase is inhibited by 5-fluorouracil or capecitabine. So capecitabine is the prodrug of 5-fluorouracil. They form 5F dump, which inhibits thymidylate synthase, which means you get a decrease in the DTMP. Fluorouracil is a medication typically IV given, so it's an IV infusion for the treatment of breast cancer, colorectal cancer, gastric cancer, pancreatic cancer. It's used for basically as a cancer treatment. And I want to talk about this DHF because that DHF eventually becomes THF via dihydrofolate reductase, and that THF circles back and becomes N5N10 methylene THF. So it's kind of a circle. You go from N5N10 methylene THF to DHF via thymidylate synthase. DHF becomes THF via dihydrofolate reductase. And that dihydrofolate reductase is inhibited by methotrexate, it's inhibited by trimethoprim, and it's inhibited by pyrimethamine. So these three drugs inhibit dihydrofolate reductase, causing you to have a decrease in the it's involved in humans for methotrexate, bacteria for trimethoprim. Trimethoprim sulfamethoxazole is what we usually use, and for protozoa we usually use pyrimethamine. So associate that with the lowered deoxythymidine monophosphate, CPS1. You'll see that in mitochondria, urea cycle. You'll see it in liver and kidney cells. CPS2. You'll see that in cytosol, pyrimidine synthesis, and it's found in most cells. So that's a lot of words. This went on a little longer than I thought. You might behoove you to re-watch this, or maybe take the time to study the pathway. It's a very complex pathway, and it's not something that you should take for granted. See you soon.